and free booklet DVD. Not only super convenient, super. In Manhattan at 38th and Broadway. Custom tailored treatment to hit the cancer. Call Dr. Lederman, 212 Choices. Cherish your life. Custom prostate cancer treatment with Dr. Lederman. 212 Choices.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212 Choices for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
We're back, and I want to talk about some good news. We had a woman who came in just Friday, so 2 days ago. She's 70 years old. She's a widow. She has one child. She has multiple medical problems. She had a lung cancer resected. She's obese. She has thyroid disorder, lipid disorder, high blood pressure, diabetes, heart disease, and she presented with a bladder cancer. And she went to a big hospital in one of the neighboring states, and she was told that there's no surgical treatment available for her. So she was hurt, but then she decided she was going to go to a big cancer hospital. She went to the big cancer hospital, and they told her that they don't take her insurance, and they recommended that she go on hospice. Okay, can you imagine that? They don't take her insurance, and they recommend she go on hospice. Hospice means end-of-life care. Now, she had a localized bladder cancer. She's 5'1", she's 260 pounds, so she's a little bit chubby, so probably not a good surgical candidate. We understand that, and probably they didn't like her insurance. We understand that. But why the heck would they tell her to go on hospice? So, she found out about us 3 months ago. She came to us, told us a story that she was going to go on hospice. They told her at the big cancer hospital she should go on hospice. She thought that was the ultimate opinion. One group of doctors wouldn't operate on her, another wouldn't take her insurance, told her to go on hospice. She came to us with localized bladder cancer. We talked to her about all the options, and I'm happy to talk about surgery because when people hear about non-invasive treatment, 99% would rather have non-invasive treatment with no cutting, no bleeding, no hospital stay. So she got treated with radiosurgery, and she was very motivated. It was hard for her to move. It is hard for her to move. She's very slow moving, but she made it in. She has a long trip from home to us for the 5 treatments. But luckily, it's only 5 treatments. We gave her the 5 treatments, and she came back now with a new PET CT scan, and guess what? Well, we've already told you it's the good news department, so she's in complete remission. Yeah, she went to a big cancer hospital. They told her to go on hospice. She went to another place. They told her they can't help her. We saw her, bladder cancer, in complete remission. So it's great news and really made me happy, and it's happy news. Makes everyone happy, especially her and her family and her loved ones and our staff. We have a great staff. We work together, and we know the patients. We know the patient's name, and we know who they are, and we know what they do. So for us, it's great news that one of our patients is in remission. Many of our patients are in remission. One of our patients is in remission that went to the big cancer hospital, and they told her to go on hospice. Wow. And another patient, similarly, a woman I treated 12 years ago for kidney cancer. She had kidney cancer 12 years ago. She came to me in 2002. At that time, she had kidney cancer. Elsewhere, they wanted to remove her kidney. She heard about radiosurgery. It was biopsy-proven kidney cancer. We treated her, and she's in remission now for 12 years. No more treatment. She just had the 5 treatments. So we make a stereotactic frame. We send the beams in. It takes about 15 minutes. She lays down. She gets a treatment. She stands up, and she goes back home. She's totally self-sufficient. She came in this week. She has a little bump on her leg. She wanted to know what it was. It was a dermatofibroma, which is a benign tumor, doesn't need any treatment. Her cancer is in complete remission 12 years later. She's going to come back in a year for follow-up, and she's got my number to call anytime necessary. A couple of minutes ago, I talked about people who come in with no knowledge of what they had. So we had a woman come in, 66 years old. She lives in South Carolina with her husband. Her sister works in Manhattan. She had a brain tumor. She had headaches in August 2013. A year ago, she had a CAT scan and an MRI in South Carolina. She transferred her care up to one of the big hospitals. She had surgery. She was okay for a couple of days, and then she deteriorated, being unable to speak, and she's had trouble speaking ever since. At the other place, she had standard radiation and chemo, and she came in with no records. She did not know the diagnosis. Her sister did not know the diagnosis. They didn't know the treatment. They didn't know anything about their situation. So we got all the records together and determined that she had a glioblastoma. She was diagnosed a year ago. She started chemoradiation. She's been on chemo ever since. We got the records from March, which is now 5.5 months ago, showing the cancer was growing, and they continued the same treatment. Well, obviously, if the cancer is growing on a treatment, the treatment's not working. The cancer's progressing. She's getting worse. She's having more and more difficulty neurologically. We got all the data together. We presented it to the family. We told them what diagnosis she had, if you could believe that. She's had the diagnosis for a year. Her sister's known about it. Neither knew what the diagnosis was. So we presented options to her. We treat many, many patients with brain radiosurgery. We were the first in New York with brain radiosurgery. We were the first in New York with fractionated brain radiosurgery. We have experience over many decades. Radiosurgery means pinpoint treatment, to aim the treatment at the tumor or the cancer, to try not to hurt the healthy brain, which is very different than whole brain radiation. Whole brain radiation hits the healthy brain, the hair, the ears, etc., whereas we can aim at the cancer. Usually the treatment is a lot faster than whole brain and more effective. For example, the control rate with metastasis with brain radiosurgery is about 90%. The control rate with whole brain is about 50%. So there's a big difference in side effects. There's a big difference in success. There's a big difference in number of treatments. And you wouldn't want your whole brain radiated if you could avoid it. I don't think. I wouldn't. I'd rather have just the cancer treated. So that's the difference, and what a difference it makes where you go. So we had another man come in with lung cancer. Now, he had chemoradiation elsewhere, standard radiation, and again, he came and we staged him up. We want to know where the cancer is, and we found a cancer still in the lung, so their chemoradiation didn't do the job. Plus, there was PET uptake in the pelvis and 2 fluid collections. Well, he had never been told that he had uptake in the pelvis. I don't think he was really staged completely. So we found that it was PET uptake positive. We're going to stick a needle in that fluid, and I'll report back to you what it is. So he's got the lung, which we know is been unsuccessfully treated elsewhere. We're going to treat it, and we're going to find out what is in the pelvis. It's unusual to have a PET uptake fluid collection in both the right and left side, but we will check it out easily, safely, and report to you. And we had a woman who was born in Bethlehem, so it thinks of biblical times, but she was born in Bethlehem in 1958. Bethlehem is in the Middle East, in Israel. In 1958, it was in Jordan. She's a 55-year-old widowed woman. She has 4 children. She has an acoustic neuroma. Now, she's had an acoustic neuroma for 4 years. She's being treated at a big cancer hospital, and they keep on pushing surgery on her. Well, her tumor is about 1.5 centimeters, and she's a pretty smart woman. She's getting progressive hearing loss and noises in the ear. She can't use the phone for the last 2 years. She's had pain behind that left ear. Her face is fine, and her gums are fine, and her teeth are fine, and her balance is pretty good, but she does have fatigue. Well, had she had that surgery that she felt they were pushing on her with a 1.5 centimeter tumor, she would have definitely been deaf in that ear. Now, what's the difference between deaf in one ear and having hearing? Well, it's the difference between having stereo hearing and mono hearing. If you have stereo hearing and you're walking down the street and someone honks at you to get out of the way or whatever, with stereo hearing, you know where they're honking from. With mono hearing, you have no idea. You have no idea where the sounds are coming from, and it could be the difference between life and death. And it's also quality of life. Who'd want to lose something that they have? Who'd want to lose the hearing? When there's a technology that's non-invasive, you can avoid someone's hands in your head. So with a 1.5 centimeter tumor, it's pretty much definite she would be deaf with the other technology. With us, non-invasive treatment, 97% chance she would have hearing. So it's pretty diametrically opposite. One deaf, 97% chance maintaining hearing. And also, with surgery for a tumor like that, there's about a 50% chance that she'd have a facial paralysis, meaning that she couldn't close the mouth on that side, she couldn't close the eyes on that side. When she smiles, half her face goes up and half goes down. Who wants that? So they've been pushing surgery on her for 4 years. She came to us for radiosurgery. We actually have the largest experience worldwide using fractionated radiosurgery for acoustic neuromas. So I have a lot of experience. If you have an acoustic neuroma or want to talk about it, I'm happy to talk about it with you. And we had a new patient who came in, was sent by a urologist, a 57-year-old man he's a black man. And again, why do I say it? Because his prostate cancer and the mortality rate is 50% higher for prostate cancer in black men than white men. So be careful what treatment you get. Yes, people really die of prostate cancer. There's about 40,000 men a year die of prostate cancer. It's a lot. So his PSA was 4.15, so it's not that high, right? He's 57, PSA 4.15. But the biopsy, they took 12 pieces of the prostate. 11 of the 12 had cancer. So his prostate's filled with cancer, and some of that cancer was Gleason 8. And I showed him the data. The data's in our booklet, and I'm happy to send you the booklet at no charge. If he went for surgery for a Gleason 8 cancer, went to the most famous surgeon in America, guess what the success rate is at 5 years for Gleason 8 cancer? The success rate's 41%. At 10 years, the success rate is 23%, meaning almost 80%. 77% of the men with Gleason 8, 9, 10 cancer have failure. They have recurrence of their cancer after radical surgery in the best hands. I'm not talking about average hands. In the best hands. Okay, and if you look at our data versus surgical data, and there's another graph so you can easily see that, our data shows 120% improvement over radical prostatectomy for Gleason 8, 9, 10. This is the data based on 3,000 men that we've been following for more than 20 years, and we update our data. So it's pretty clear for this man with a Gleason 8, he can go elsewhere and have a 30% or do 120% better with us, and also more likely maintaining his sex life and urinary life, and we have the data for surgery. Sexual problems after surgery, 97%. Urinary problems after surgery, 80.8%. Most of our men maintain their quality of life. This is a very different, sad quality of life after open surgery, whether it's robotic or open. This is figure number 21, page 14 of our prostate cancer booklet. This is Dr. Lederman talking about cancer. We're a cancer treatment center in Manhattan. We're going to hear from a couple of voices, and they'll be right back.
For cancer treatment, most prefer effective, non-invasive, well-tolerated outpatient therapy. With Dr. Lederman, the radiosurgery pioneer, that's our goal too. He's first in America. First in New York, first for